Okay, good afternoon. Thank you all for waiting. Um, my name is Patty Katz. I'm the president of Reach Out America. And since our last webinar, many changes have occurred. Actually, as of today, the House is in the process of impeaching Trump for the second time, which is the first time in American history. Officially, we now have a Democratic president and vice president-elect to be sworn in on January 20th. But they'll take their oath with a country that is deep in turmoil and division. Just a week ago, we witnessed Donald Trump inciting an angry group of insurgents who stormed the Capitol. These rioters were intending to execute both Mike Pence and Nancy Pelosi. They carried assault weapons, Confederate and Trump flags, wore racist clothing. They were disrupting and destroying everything and everyone in their path. There was a total lack of security enforcement for an extremely long time, which made it appear to be a coup attempt to many, which probably was. The FBI is going to be checking that out. 8 senators and 139 congressmen and women continue to support the lie of a stolen election, and some aided the rioters, while Trump and his family and friends were watched from a bunker underneath the White House, cheering them on. There are many warnings of continuing violence across America. While many Republicans still deny their responsibility to protect the Constitution and the American people, in light of this, we didn't even have a chance to celebrate the huge victory in Georgia, with Senators-elect Warnock and Ossoff turning Georgia into a very bright blue state and giving Democrats the majority in the Senate. And just again, I want to thank Sandy Salek, because if it wasn't for her, we would not have been able to help with so many of us writing postcards to Georgia. So thank you, Sandy. This is a very dire time and a big turning point in our country. This will not turn around overnight, as it's taken a long time and many years in the works. So Gabby Giffords recently wrote an article in the New York Times about gun violence, her struggles, the struggles we're facing in this country. And I'd like to end with her last paragraph, as I think she sums up where we're at much better than I could. There's no magic recovery in store for us as a nation. We have a long way to go. We're living with consequences of years of inflammatory speech and false accusations. Through hard work, intention, and commitment, our country will overcome the rage of those who stormed the Capitol with Confederate flags and symbols of hate. We draw strength from the bravery and determination of our first responders and frontline workers. They inspire me. We will move ahead together, as I did and still do every day, one foot after another. When one person flags, another person steps in to lift up the weak and give strength to the doubtful. Together, our resolve and determination will be fuel for the years to come. With all this chaos, this is me speaking now, with all this chaos, the COVID pandemic has taken a back seat. We'd like to focus on this timely topic today, and I'd like to turn the virtual floor over to Rita Hall. Let me just get her up and running here.
Hi. Some years back, my elderly mother took a fall on the street, and the EMTs said they wanted to take her to Elmhurst instead of a nearer hospital because it had one of the best emergency rooms in the city. When we met her there, we saw a mixed crowd. Some uninsured waiting for help with minor illnesses, others rushed there with life-threatening ailments and everything in between. Amid the friendly chaos sat my mother alongside a woman in orange, shackled to her gurney, guarded by a cop with a hand on his holster. Rikers prisoners are among Elmhurst's diverse patient population. In relatively short order, my mother was treated and out of there, and indeed the care and attention was wonderful. A few months ago, Elmhurst Hospital appeared on our radar because it had become a pandemic epicenter. Our guest speaker today, Dr. Joseph Masci, an internationally recognized expert on HIV/AIDS diagnosis and treatment, general infectious diseases, tropical medicine, and emergency preparedness, who'd been head of medicine at the time of my mother's visit, is now the founding chairman of the Department of Global Health at Elmhurst Hospital Center, as well as a professor of medicine and preventative medicine at Icahn School of Medicine at Mount Sinai. He is the physician consultant for the vaccine rollout at the New York City Health and Hospitals Corporation, the group that runs the 11 public hospitals in New York, and chairs its COVID research committee. Dr. Masci was one of our guest speakers at Reach Out America's Science Forum 2 years ago. At the time, he predicted that the planet would face many worldwide health challenges, likely including a pandemic like the one we are now living through. Clearly, one of the things we've all learned is that we should listen to the scientists because they both knew what was coming and also will be the ones to lead us out of this current disaster. It is my great honor to introduce Dr. Joseph Masci.
With Zoom. Thanks very much for inviting me. It's a great honor to speak to this group. COVID-19, I think maybe 13 months ago, none of us were suspecting anything like this was about to befall the world. And it has been an incredibly difficult and tragic year. The number of deaths from this pandemic in the United States has gotten over 4,000 a day recently. That is many more than were killed in the World Trade Center attack. And the overall mortality so far of COVID-19 is approaching 400,000. HIV/AIDS has caused 700,000 deaths in the United States, and it's taken 40 years. This has taken 12 months. So let me go through a brief presentation, and I'm happy to answer questions later. There's a lot going on this week in terms of COVID-19 and the rollout of the vaccine, which has not been as smooth as everybody had hoped. So let's get started. Okay, so I mentioned in general the idea about coronaviruses. You can hear me now, I guess, right?
Oh, yes. Thank you.
The novel coronaviruses, there have been 3 of them. The one that caused the severe acute respiratory syndrome in 2003. The one that is more recent, it caused the Middle Eastern respiratory syndrome. That spread from camels to people, probably bats are in the loop somewhere. And that is an ongoing outbreak that occurs every year around the time of the Hajj. Both of those infections, the one in 2003 and the one since 2012, were highly lethal and dangerous. They both carried about a 35% mortality. Now, the 2019 version of the coronavirus is not that lethal, at least not at this time. But exactly why it spread so quickly around the world is a mystery. I'm skipping over some maps demonstrating that. Now, why did it start when it did? Again, it's not clear whether this was a simple, strange, minimal incident at a Chinese food market that enabled pangolins or snakes or bats to transmit this to people. But as we all remember, last November and December, there was a rising level of concern and even panic in China, in that part of China, as the cases began to expand. And one of the doctors who was most involved in taking care of patients died relatively quickly from this. So the danger to healthcare workers was immediately obvious. And what exactly it was going to take to prevent healthcare workers from getting this infection was not 100% clear yet. This virus is very similar to the SARS virus that occurred in 2003. It's actually quite different from the one that has occurred in the Mideast. And that is a reminder that this is a large, complicated virus. It has the potential for many different subviral species. And it also, as we've seen now, has the potential for mutations that can have really important clinical relevance. So how does it attack? It's primarily a respiratory pathogen. It attacks us by inhaling it, attacking the respiratory tract cells. It attaches by what's called the spike protein. This virus looks a little bit like a Sputnik. It's round and has spikes all over it. The spike protein allows it to attach to a receptor on our respiratory tract cells. It then gets into the cell, divides, leaves the cell again, often kills that cell and spreads to other cells. So that spike protein has attracted a lot of attention as a possible way of preventing infection with this, or even treating infection with it. It is the single attachment protein that's most important in connecting this virus to our cells and causing disease. So how does it actually cause disease? Well, we know it is more contagious than some viruses and less contagious than others. Sort of the epitome of a contagious virus is measles. For everyone who has measles, who is in a non-immune population, they will infect between 12 and 18 other people in that closed space population. Nothing else is quite that contagious. If we work our way down other contagious viruses, smallpox, mumps, etc., they're less contagious than that. They're more contagious than coronavirus. Now, coronavirus has what is thought to be an R level, that is the number of people that can be infected by one person who is transmitting the virus, between 1.5 and 2.5. And that is bad news. That allows the epidemic, the pandemic, to proceed until we get effective countermeasures. So 1.5 to 2.5 people on average who are exposed to someone with COVID will get COVID. Now, where does the pandemic stand right now? Unfortunately, it stands in a particularly tragic and alarming place. The daily infections are going up and up. Now, this is just the number of people who have had tests that are positive. That does not give you the full picture of how tragic this has been. Since we know that the majority of people who test positive don't actually get sick, it's really important to also look at the number of people who've been hospitalized and the number of people who have died. I think we've all heard President Trump say, well, it can't be that bad because it doesn't infect that many people. All of that is complete nonsense. As of 2 days ago, there were 129,000 people hospitalized in our country with COVID. The 7-day average was actually over 130,000 people. This is 130,000 additional hospitalized patients over what we would normally have. The daily death rate has reached over 4,000 a day several times in the past week and is consistently over 3,000 a day. That is a shocking and a depressing number. We all have to keep in mind what that number actually represents. That's not just illness, that is deaths, deaths from a viral infection. We have never seen anything like that before. Even the 1918 flu epidemic was much more rapidly curtailed and did not lead to that many daily deaths over this long a period of time. In the United States right now, the situation is particularly murky and tragic. There is not a state in the United States that does not have an outbreak. The size of the outbreaks is the only thing that's different. As we've all heard, Southern California is being particularly hard hit, but New York is still involved, the upper Midwest, Florida, the southeastern states. The entire United States is being impacted by this. Let me just pause for a minute and try to figure out why that's true. When we compare the United States to other countries that have dealt with this outbreak, nobody has had an easy time of it. But since we have 50 different sort of independent governments that can make their own decision about control measures, it has been very, very difficult without stronger federal national leadership to bring this under anything like meaningful control. When we get to talk about the vaccine in a few minutes, I want to underscore how important it is that we get this under uniform control across the United States, because if we don't, we will never bring it under control. Now, many of us have heard, and it's true, that different populations seem to be affected differently by this. The highest death rate has been among Black and African American people, followed by Hispanics, followed by Asians, followed by Caucasians. Why is this true? The answer is we don't really understand why it's true. It's certainly possible that there are genetic features that make one person more susceptible than another, or one person more likely to die than another. But it's more likely that these statistics represent the living conditions of people from those communities. We know in Elmhurst, there is a vast population here of both Hispanic and Black African American people. Many of them live in very crowded circumstances. In fact, in this community, there are many unregistered immigrants who live in illegal apartments, and that they've been subdivided and subdivided. So they're in very crowded circumstances, even more crowded than the apartment was designed to provide. And we see from these outbreaks that we are frequently seeing now, where one person comes in and the rest of the household is all infected, that it probably has a lot to do with this close proximity. Adjacent neighborhoods to Elmhurst don't have quite the degree of crowding. When we look at Forest Hills, for example, they have a significantly lower rate of COVID, and it's probably due to less crowded living conditions. Now, as we look forward, what is actually going to be the strategy coming out of all of this? Whatever happens with a vaccine or with treatment, we also have to take a very serious look at the living conditions and the crowding that occurs, and do something about it that is meaningful and longstanding. Now, the clinical illness. After infection, about 80% of people will have either no symptoms or symptoms that are not severe enough to require hospitalization. 20% will require hospitalization, and 5% of the total will require intensive care. Last spring, we were absolutely inundated. We saw many more patients than this hospital has capacity for, and we had to make a lot of creative solutions in order to take care of them and provide sufficient staffing for them. Unfortunately, these patterns are occurring again. This hospital is not quite so overwhelmed. In fact, New York State has put a lot of steps in place to help prevent a rapid surge, but we're seeing this rough breakdown again. 20% of infected people require hospitalization, and 5% require intensive care. Today at Elmhurst, there were 4 patients who expired. All of them expired from COVID. The death rate from this disproportionately is highest among elderly people. It begins to climb above 1% above the age of 55. Nearly 3% between the ages of 65 and 74. Over 4% in people between 75 and 84, and over 10% in people over 85. Exactly why it is so dangerous to the elderly, we don't fully understand yet. It may have something to do with the host response or other conditions that population may suffer from that puts them at higher risk for anything, but it is really quite striking. Now, the newer viral strains that have been described may be circulating more effectively among young people, but so far that has not been demonstrated in these horrible death rates. It is primarily a respiratory pathogen, but unlike other coronaviruses, it doesn't just stay in the respiratory tract. So the common symptoms are fever, a dry cough, a flu-like illness, but in severe cases, shortness of breath, chest pain, coughing up blood, respiratory insufficiency, just difficulty breathing. And then specific complications include pneumonia, cardiac injury, this has been seen often in athletes, arrhythmias, liver problems, acute kidney injury. We had many patients who came in the spring who required emergent dialysis, and multi-organ system failure. So this is a devastating infection when people get that 5% severe form of it. It's hard to stay ahead of it. It can really produce more damage than the patient is even aware is happening by the time they come to the hospital. But we've had many patients who required intensive care management for months with the severe version of this, and that has not changed or gotten any better. The only thing that may be getting somewhat less severe are the clotting problems that were described early in the outbreak. We saw lots of people with problems with blood clotting that we did not understand. We've learned to treat for that, to prevent that. The acute kidney injury may be getting a little less common. Whether this has something to do with changes in the virus or changes in treatment, we don't know. I'll come to treatment in a moment, and you're going to see that treatment has a few things have been studied, but very little has been shown to make a difference. Now, with the pulmonary version of this, the primary end organ that's involved with this. The primary end organs are the lungs. Extensive chest X-ray abnormalities can be seen in these patients. I wish you could see the picture that I have in front of me. We've had many patients who were sick and had these really characteristic changes on their chest X-ray of these widespread patterns of consolidation and inflammation. But in addition, we've had many patients who were not very sick and had that same pattern. In fact, in the spring, about 40% of the women who came in to deliver were COVID positive, and many of them had this sort of pulmonary and respiratory involvement. We're looking now to see what happens. We have a large-scale project looking to see whether these lung changes go away with time after a person is home and feeling better, or whether they get worse. And this is one area that I'm particularly worried about. Is COVID the tip of a big, broad, ongoing iceberg that we're going to see going forward? Even after we can treat the acute infection, are we going to be seeing these end organ syndromes that go on and on and on and compromise the health of these people going forward? Let's hope not, but the data that some of you may have seen that was published from China last week, I think, indicates that between 60 and 70% of people who seem to have recovered have what are called long hauler symptoms of COVID. This is a bad thing to get, and we don't understand what the ultimate outcome of it will be in most people. So the non-pulmonary features I've mentioned, to say a word about that long hauler problem, this has been most documented and most evidenced in athletes, because as many of you follow sports may know, a lot of athletes in the professional sports had to sit out this season because they had long-term complications and recovery problems after COVID, often affecting the heart, inflammation of the heart. Now, was this particularly obvious in these young athletes, or is this more prevalent in lots of people? We don't know yet, but it is another reason why we have to be very careful to prevent further spread of this infection while we're waiting for widespread vaccine. Now, the therapeutic options, as I've mentioned, these are very limited. And I'm not trying to make this overly scary, but we've heard a lot about various treatment trials of various drugs. Really, nothing has been shown consistently to be effective in terms of a treatment other than steroids. Now, steroids that's a treatment strategy we've used for decades for a variety of different things. And in people with COVID who are requiring high flow oxygen in the hospital or who have to be placed on a ventilator, dexamethasone, a common corticosteroid, can improve their prognosis. Other things are now coming along, and I'll talk in a minute about the monoclonal antibodies, which are now being made available more widely and can treat COVID even in an outpatient setting. But that's still a very preliminary set of findings with those types of drugs. So right now, and as Dr. Frieden, formerly the head of the CDC, said yesterday, steroids are the only drugs so far that have been shown to work. So what are we trying to do about all of this? Well, we're trying to control the transmission of this outbreak. In New York, one of the reasons why New York has done a little bit better, a lot better than it did in the spring, and a little bit better than much of the country, has been really wide-scale testing. They're often testing over 100,000 people a day in New York City for COVID, and giving advice to people who have COVID about home isolation and quarantine, et cetera. That is the way to prevent widespread transmission and to prevent the rapid acceleration of cases that we saw in the spring here and that many other parts of the United States are witnessing now, particularly Southern California. We're trying to get ahead of that as we tried to in the spring, and hopefully now we will be able to. We have a better understanding of this. We have a very good system in New York for contact tracing. It's one of the most effective in the country. If you are ever contacted by the city health department that you are someone who has been in contact with a proven COVID case, please listen to their advice about home isolation. That is how we can get this under control even before the vaccines really take hold. Now, there have been these novel strains of the virus that have been described in the past month. The one that has been most worrisome has been a viral strain called B117. This was reported in England, and it is widespread now in England. And it's one of the reasons why England has gone into a late shutdown again. Now, what's different about this virus? This virus, this strain of the virus, attaches somewhat differently to that spike protein. Rather, its spike protein differently to the cell. And because of that, it can create a larger viral load earlier, within the first couple of days of infection. And when that happens, a person is more able to transmit the infection earlier. Now, that virus strain, B117, has been documented practically every place they've looked for it. It's been seen now in 33 countries, in 5 states in the United States. Just so you know, in New York State, we're just now gearing up to look for these specific viral strains. Next month, we will have a much more robust program to look for what we're actually seeing. And are we seeing these coronavirus strains that have different features? So far, it looks like the vaccine is effective at preventing this one. But let's remember, this emerged before any vaccine came out. These mutations are occurring anyway. And when a mutation occurs in a virus, the way to prevent it from accelerating and perpetuating itself is to prevent infection. Viruses mutate only after they've infected our cells. So if we could prevent future infections with an effective vaccine campaign, we can prevent future mutated viral strains, including ones that may be much more dangerous than this one. So in addition to B117, there is a peculiar strain that some of you may have read about. It's called cluster 5. This was found in farmed minks in Denmark in August. It's presumed that those minks were infected by people, and that they transmitted it among each other, and that they then were able to transmit it back to minks. In response to that, Denmark culled its mink population completely. They had millions and millions of minks that were killed in order to prevent this cycle of transmission. Of course, there are mink farms in other countries as well. And mink farms in this country have taken similar steps, and in other countries around the world. So far, this cluster 5 strain has not been seen again since August. It infected about 200 people. It seems to have the same features as the other strains. And as we begin to do more testing and looking for viral strains in this country, we're going to have to be on the lookout for this one. Then finally, among the novel strains is a particularly frightening one that's in South Africa. This is called strain 501v2. It has caused a dramatic increase in cases in South Africa, just like the one in England has caused a dramatic increase in cases there. It is believed to have something to do with travel back and forth to England, although it is a different strain than that. But travel to South Africa from Britain has been relatively open for a while now, and it's thought that these viral strains may have found a particular route of transmission that way. It is thought to be more transmissible, just like B11, but it's so far not thought to be more deadly. So what's the difference between that one and the typical strain that we are aware of? Well, that one also has alterations in that spike protein. So far, it looks like the vaccines will be preventing that one from spreading further, but we have to keep in mind that just like the one in England, this one started before any vaccines became available to anybody. So this didn't mutate in response to a vaccine. This just mutated. And future mutations may be far more dangerous than those that I've described that we've become aware of so far. Now, the questions that all of this raises about with these new strains is what will be the impact of this increased transmissibility? When we talk about the vaccine in a few minutes, we're going to talk about the concept of herd immunity. What proportion of our population would have to be effectively vaccinated to really put a stop to all of this? That depends a lot on how transmissible the virus is. If these more highly transmissible strains start getting a foothold, we may need to vaccinate a higher proportion of the population, maybe over 90%, to really get control of this. So far, the population needed to be vaccinated is thought to be between 70 and 80%. But let's keep an eye on that because it may change quickly. So let me mention briefly the monoclonal antibodies. Now, as I mentioned, SARS-CoV enters the cells by binding the spike protein to certain receptors on the target cells. There are two drugs, now three really drugs, but two preparations of drugs that have come out that contain monoclonal antibodies, and they neutralize, bind to, and block the spike protein. Again, it's that spike protein that everybody is focused on. These have been shown in animal studies to be effective, and in a published study of the monoclonal antibody preparation made by the Lilly company called LY555 that came out a few months ago, it was shown to be effective at preventing symptomatic disease in about 90% of people who got it. On the basis of that, the emergency use authorization was given to this preparation and now similar ones to provide its availability in limited quantities to outpatients who have symptoms of COVID but are not sick enough to be in the hospital. Now, when I say it that way, you could say, well, why just outpatients? Why do they have to have symptoms? Why can't this be given to everybody? This is the byproduct of the rapid rollout of all of these strategies. The vaccines and these various treatments were studied in certain ways with certain populations. And those are the only ways and only populations in which we know they work. So therefore, they're initially restricted to be used the way they were studied. If this had been a more standard rollout of treatment, we would know a lot more about who else could be benefited by this. But so far, these drugs are designed to be given to people who are symptomatic but not desperately sick, outpatients, and have certain risk factors for progression to get much sicker. And those risk factors predominantly reflect the age of the patient. So if they're over 65, or if they're over 55 but have cardiovascular disease or hypertension or chronic respiratory disease, or if they're younger people who have a very high basal metabolic index over 85th percentile and a variety of other medical conditions, they can be considered to get this treatment. We've started rolling this out throughout the city hospital system. Some of our hospitals have given a lot more of it than others, but throughout the entire public hospital system in New York, there are only about 100 doses of this available. So it's being used very cautiously in a very focused way. And we have to keep our eye on this because it could represent a really important step forward in treatment, particularly of outpatients. Up until now, we haven't had nothing we could offer to outpatients. We only had treatment for inpatients. So to briefly summarize what I've said so far, the origin of COVID-19 is still under investigation. The pandemic spread of this probably reflects the reality of global travel. Interestingly, Africa has been so far relatively spared, and that may mean simply that there was not as much travel to Central Africa during the early stages of this outbreak. Respiratory spread is the way in which this spreads, so masks are incredibly important to prevent its spread, but findings outside the respiratory tract, as I mentioned to you, are frequently extensive and extremely dangerous. Antiviral treatments and other inpatient treatments we've used other than steroids are questionable value at best. And the variant strains of the virus are already appearing. Rapid vaccine rollout to achieve herd immunity is the only way out of this. So let's talk about the vaccines. Now, vaccines have been the most important medical advance in the last 100 years or more. We've brought horrible diseases under control with vaccines. Smallpox has been eliminated. Measles has been largely eliminated for most of the developed world, as well as mumps, pertussis, rubella, polio. Tremendous success, and it's been pointed to again and again that without vaccines, we would be helpless against these diseases. So let's keep that in mind as we talk about the pluses and minuses of a vaccine. Now, the percent vaccinated has a lot to do with how herd immunity works. If, for example, we can get, say, 95% of the population vaccinated and the vaccine is effective and protective, Why does that prevent progression of this whole thing? Well, if you're surrounded by people who are immune to this because they've been vaccinated, even if you get this infection because you haven't been vaccinated, you can't transmit it very well. The R number, that 1.5 to 2.5 number of the number of people you can transmit this to, drops to far less than 1. And that's how this outbreak will be brought under control and extinguished. Because when that R number is less than 1, the number of people who you can even potentially transmit it to, then the outbreak will be over with. So that's why we have to aim for that range of vaccinated people, somewhere between 70% on the low end and 90 or 95% on the high end. Now, so far, the vaccine rollout in the United States has been a problem. There are 2 vaccines that have come out so far. They both received that same emergency use authorization by the FDA in December. Vaccination rates have been slower than necessary, due both to logistical and supply issues. The states with guidance from CDC determined how prioritization should work. CDC dictated these provisions. So the first people to get the vaccine were healthcare workers like myself, then first responders, and then people over the age of 75. Now, so far, approximately 9 million people have received the first dose of one or the other vaccine. That's out of 23 million doses that have been distributed. Now, what is the problem? Why can't the vaccine be distributed more broadly and more quickly? So first of all, let's remember how the vaccine works. This is one of a number of different types of vaccines that we're going to be hearing about. These 2 both work by injecting a manufactured messenger RNA that codes for the spike protein. It gets into your cells, starts making the spike protein. It binds to the receptors that block the virus from entering the cell. And these vaccines, both of them, both the Moderna and the Pfizer vaccine, seem to be about 95% protective. Other vaccines that are coming, the vaccine from Johnson & Johnson uses a different mechanism. That should be coming within the next month or 2. Both of these current vaccines, Moderna and Pfizer, require 2 doses, either 3 weeks apart or 4 weeks apart. The Johnson & Johnson vaccine will require 1 dose. There is another vaccine that is in the works, and that will be coming probably over the next few months. So there will be a variety of different vaccines available to us. Allergies to the vaccines have been overrated and overstated. The CDC put out a study last week looking at the first, I think approximately 900,000 people who had received the vaccine. After either first dose of either vaccine, 1 in 90,000 of people getting it had had severe allergic reactions. Of those patients, and that was 21 people, 19 were women, 2 were men. Almost all had symptoms immediately. Nearly all were treated with an EpiPen, the epinephrine injection that we give in emergencies. 4 were hospitalized. All have now been discharged. The people who got the vaccine who had these reactions all had significant allergic histories. So what we ask people about is, do they have a history of a life-threatening allergic reaction that had, prior to this vaccination, required hospitalization? Do they carry an EpiPen? Those are all markers of people who might have another severe reaction. So we caution them about it. Sometimes we tell them, let's not give you the vaccine yet, but that is a tiny, tiny fraction of people. Another category of people that weren't studied, unfortunately, in these studies that led to the release of these vaccines were pregnant women. Of the 70,000 people in the clinical trials who got the vaccine, about, I think, 50 turned out to be pregnant. They didn't know it at the time that they got their first injection. And there were no negative outcomes of those pregnancies seen. There was 1 miscarriage seen, but that was in the control group that had gotten a placebo. So the obstetrical societies are recommending that pregnant women get this vaccine. The danger to a developing fetus or to the pregnant woman herself of getting severe COVID cannot be overstated. We had cases in our hospital of severely sick pregnant women, and we cannot risk that. And again, if we start eliminating subsets of the population, like pregnant women, we're going to start dropping the number of people who are eligible for the vaccine and falling short potentially of the herd immunity numbers. So what are the problems with this vaccine availability? One, the vaccine distribution through hospitals has been too slow. It was never a good plan to do all of this vaccinating through hospitals. As of yesterday, New York State has administered 41% of the doses it got, mostly through hospitals. The best state in the union, believe it or not, has been South Dakota, that has been administered 5.5%. The worst has been Georgia, 1.1%. But none of those percentages are where they should be. So of the 9 million administered doses as of yesterday, across the country, only 3% of the population has been vaccinated. Now, new federal guidelines were expected this week, and they actually came out yesterday. So now the vaccine rollout is supposed to go to everyone 65 and older, reflecting the high rate of bad outcomes in people over that age. Occupation doesn't matter in that group. Nothing else matters. If you're 65 or older, you're now a candidate to get the vaccine. But this is a CDC guidance. New York State is scrambling to come into compliance with this. They have opened up additional vaccine centers, the Javits Center, Citi Field, et cetera, in it beyond the hospitals that were giving the vaccine exclusively, to allow people to contact them and make appointments to get the vaccine. But because there is now a sudden rush to get the vaccine strictly on an age basis, the waiting time could get longer, and it may be several months before you can get an appointment. So right now, if you ask me as an infectious disease specialist, how many people should be vaccinated right now if we want to prevent this from getting much, much worse? Everybody should have been vaccinated by right now. That was never going to be possible. So we have to keep our eyes open for how the vaccine rollout is going and whether the distribution centers are adequate, whether you can get appointments. I'll show you some web links where you can go to try to make an appointment now. And we have to all be aware that the longer the time goes by that we don't have sufficient numbers of people vaccinated, we will continue to see progression of this epidemic and potentially emergence of vaccine-resistant strains. So for now, they've divided this into several segments of vaccine release. The people who are eligible are all healthcare workers, all first responders, all correction facility staff, prisons, all teachers from pre-K to grade 12, all in-person college instructors, all group child care providers and staff, all public transit workers, all public safety workers, all resident staff and patients of long-term care facilities, all public-facing grocery workers, and as of yesterday, people over 65, all of them. All vaccinations can only be made by appointment. You have to get an appointment through the websites that I'm going to show you, and we'll distribute the slides after the lecture so everybody has this. The next eligible groups. The rest of the 1B, that second eligible group after healthcare workers, will be other frontline essential workers. That's going to be determined by New York State, and that's going to start in February. Other at-risk groups also will be determined by New York State. And then comes phase 1C. That will be people with certain underlying health conditions as identified by New York State, and everyone else who's an essential worker. That will start in March. Phase 2, which is basically everybody else, including hopefully younger people, that will be starting in the summer. Now, all of these deadlines are theoretical deadlines. They are not anything that the law is going to require us to do. We just all have to be cooperating with this. We all have to do something we've never had to do before. Look for places to get the vaccine. See to it we get vaccinated. And please, I give a talk every Friday to a group of about 600,000 people on the radio and television, many of whom are African American, from the Caribbean, or Hispanic. There is great concern about the vaccine among that group. We have a lot of work to do to assure people that the vaccine is safe, that it has not been selectively created to protect white people. So please, if you have no concerns about your own safety in getting the vaccine, please get the vaccine as soon as you can sign up for it. If it's got to be in April or May, sign up for it. If you can't sign up for it, they will take your contact information and contact you when you can sign up for it. If we all just get in line for this vaccine, we can begin to hope to approach that critical number of 70, 80, or even 90%. So while we work with people who have a genuine fear about vaccines based on how their racial and ethnic groups have been treated in the past by the medical profession, while we work with them to improve the understanding of the vaccine and the understanding of the safety, anyone who understands that this will be safe and protective should move ahead to try to get the vaccine. Okay, now I have a slide. Again, I will distribute these. I hope we get this out to everybody. As of today, they're giving it out at the Javits Center. These are the centers right around New York City. As of tomorrow, Westchester County Medical Center. All these will continue to give it out after that. As of Friday, Jones Beach. And after that, Stony Brook and a variety of other places. These will be announced. And if you're looking for the latest information on this, just go to the New York State Department of Health website on your internet, and you will find it where you could go for the vaccine. Again, I will send out the phone numbers to schedule an appointment and the website address to look into this. So let me stop there. Sorry about the slides. I hope this has been relatively understandable even without them. I just want to remind you all, the vaccine is going to be our way out of this. The country is in a horrible place right now. And as always happens in our country, we're always distracted by other things. I think at the end of the day, if we can actually get ahead of this, it won't matter who's president at that point. This is going to destroy us unless we get a good handle on it. And as I said 2 years ago, there are other viruses on the way. We can't control this. They spread because of international travel. We don't know where the next one is coming from, how transmissible or how dangerous it will be. So please, let's get ahead of this one while we have an opportunity to. So let me stop there and see if there are any questions or comments.
Thank you so much, Dr. Masci. That was, even though you didn't have your slide presentation, it was really terrific.
Thank you.
Very informative. You answer, I'm sure there's going to be a lot of questions. So if people have questions that are attending this webinar, just go to the Q&A on the bottom. I see Dana Epfin already asked a question. She wanted to know, should I be worried with a loose cough that started 24 hours after the vaccine? It's not persistent and she has no fever.
There's so much COVID circulating right now that even people who've been vaccinated maybe were incubating the infection at the time they got vaccinated. We've seen a number of people here who got their first dose and tested positive for the virus a few days later. So if your cough is gone now, and you haven't been contacted that you've been in close contact with someone who had the virus, I think you could just wait, see if anything gets worse again, and not get overly concerned about what you're describing. Get your second dose of the vaccine and move ahead with it. The vaccine is protective. Even one dose of it of either of these appear to be effective in about 80 to 90% of people. It's that second dose that we need to get us up to 95%. So I think from what you're describing, I would just sit tight.
Great. Mira asked, what's the name of the drug being considered for outpatients? Would you please?
Okay, it doesn't have a name. It has a hard to pronounce name. So it's called Lilly 555 or bacilamidud. And those are the names of these drugs are also on my slides. There are two preparations. One is from the Regeneron company. The other is from Lilly. Either one of those would be known to your healthcare provider, and you can just ask them which one they have available. Right now, we're using the one from Lilly because the other one hasn't been that available yet. That's LY555. And as we go forward, many other companies are looking to develop similar drugs. So within the next few weeks, we're going to be hearing more and more and more of this type of treatment. But right now, we've had a number of people who have asked about getting these treatments, but at this point, they are restricted by the FDA to people who actually have symptoms, who fall into one of those high-risk groups, particularly people over the age of 65 or over the age of 55 with chronic medical conditions, with symptoms of COVID, though. If you have no symptoms of COVID, you should not be getting these drugs. because we don't know how effective they are, and they need to be reserved for people who do have symptoms.
Thank you. Okay, Rita asks, you said by summer would be the phase 2. So I guess when do you see that this might all be finished as far as all the inoculation? Are you talking about the fall? Is that?
Yeah, I think if you listen to
It's like
Dr.
an answer.
Fauci closely, he keeps putting the endpoint to this later and later and later. And now he's talking about next fall. I think that is realistic. Let's say we get effective herd immunity, we would begin to see a major impact on transmission well before that. It's even estimated that this month, with the several million doses that have been distributed so far, we may begin to see an impact on transmission even this month. So we're going to have to keep an eye on these numbers as we go forward. But until transmission is basically stopped, we're not going to be able to say we're out of this. And at this point, I think next summer is maybe a little ambitious for phase 2. Hopefully it will come to pass. But I think Fauci is probably right that we're talking about next fall at this point.
And with the vaccination, is this something that we're going to have to take over again, like in the following year? Or is this something that's supposed to really like work indefinitely?
That's such a good question. What we know is after naturally occurring infection, people get antibody, and those antibodies can be protective for at least several months. Now, after the vaccination, it's estimated that the protection will be at least that long again. In fact, there was a study that came out this week indicating that after the Moderna vaccination, it's anticipated that that would provide at least 8 months of protection. But the reason I keep saying at least is we don't have any long-term follow-up yet because these vaccines came out so quickly. So we really don't know that. It's possible that this will require annual vaccination or an annual booster or tailored vaccines going after new strains. I just want to keep everybody focused on the idea that what we're facing is complicated and we're not anywhere near out of this yet. The best case scenario would be if these current vaccines are effective for years. We don't know that yet, and they're effective broadly. That we won't know the answer to for at least another few months or maybe even a year. So right now, let's keep our options open to anything we may hear. The companies are working hard and the FDA is working hard to make the decisions on when and if some form of revaccination or booster would be needed.
Great. Justine asked, can you get COVID-19 more than once before vaccination?
Yeah, well, there have been a handful of cases. We were very worried about this for a while because there have been some cases around the world, maybe less than 20, that describe this. People who seem to have recovered from COVID and got it again. Now, that seems to be a very, very unusual occurrence now that it's been looked at more carefully. So it's said now that if you have COVID, you can remain positive for the antigen for up to 90 days after that. But that doesn't mean that you can still transmit it, that you can infect other people. It's assumed that if you have the infection, you can only transmit it for about 2 weeks, even if you still have antigen positivity, these breakdown products of the virus that are still in your respiratory secretions. So 90 days is that window we look at. If you've gotten reinfected with COVID after 90 days, that's considered an actual reinfection. If you simply test positive again and again and again in those 90 days, that's not considered a reinfection. That's considered the first infection. And after 2 weeks, you can't spread it anymore.
Oh, well, that's good news. I have a question. I heard that the vaccines are not live, which is different from
Correct.
usual, right? They're from RNA. So can it affect generations to come when those people who are inoculated give birth? Do we know this?
Well, we don't know obviously yet. The vaccine studies have not been carried out, but in pregnant women. But you have to keep in mind the messenger RNA that's used in this vaccine is synthetic. It's not a component of human RNA. They make it so it can make the spike protein. It's injected, it gets destroyed quickly by the cell, and what's left behind are the spike proteins that it generates. So it does not seem very likely to me, at least, and I don't think that anyone else who's looked at it carefully, that it's going to affect our genomic properties, our ability to have children, or could it cause infection in developing babies? It just does not seem plausible that that would happen. But, these are new style vaccines. These are the only human versions of these vaccines that have ever come out. This type of vaccine using messenger RNA, though, had been looked at for over 10 years in a variety of different laboratory animals. They did not find any problems with reproductive states in those animals. But again, this is part of the issue with the rapid acceleration of this vaccine release. We needed this. It's going to save a lot of lives. Some of these issues have to be addressed going forward, but so far there's no evidence that this is dangerous in pregnancy.
Great. All right. That sounds good. Nina has a question. How far away are we from getting the other kind of vaccine? She says dead virus instead of mRNA.
Yeah, the Johnson & Johnson vaccine, it's similar to the one they created for Ebola virus. That was extremely effective. That's coming out probably later this month or early next month. That is an entirely different mechanism. And it's not the entire virus, it's pieces of the virus attached to an adenovirus carrier. And there's a lot of hope that that will be as effective as these current vaccines. That only requires one dose. But as I've said in a number of other lectures in the past week, although it's expected that that will be out by the end of January or by the middle of February, we never know when there's going to be a hitch with any of these vaccine rollouts. So sitting back and waiting for the Johnson & Johnson vaccine until we have a specific idea when it will be available is probably not a good strategy right now. The AstraZeneca vaccine, which is the other one like that, has had some problems. That one was studied in a haphazard kind of way, in my opinion, where they accidentally gave people a smaller second dose. It was also a 2-dose vaccine. And they found that a smaller second dose was as effective as a full second dose. But it was studied in a variety of different countries, and it was not clear exactly why that happened. It seemed like it was actually an accident. And overall, its protective range seems to be about 70% rather than the 95% that we've seen with Moderna and with Pfizer, and is expected with Johnson & Johnson.
Okay, Rita asks another question, which I'm sure we all want to know this. Once you're vaccinated, and let's say you're in a room with other people that are vaccinated, everybody's been safe that way. Can we sit and enjoy being together without masks?
I would say not yet. One concern, again, because of this rapid rollout, people who have been vaccinated and don't get sick from COVID can still get the virus and be putting it out in their respiratory secretions, unknown to them. And we also know that 5% of people are not protected by these vaccines. So let's make a worst case scenario that you're sitting in a room where everybody got the vaccine. Somebody is not protected because they were in that 5% and they don't know it. And somebody, or maybe more than one person, is still coughing up virus and they don't know it because they had the vaccine, it was effective, but they're still carrying the virus. They could infect that person who was not effectively vaccinated. Now, as confusing as that may seem, we're going to know much more specific answers to that kind of question within the next few months, because there's going to be a lot of experience with vaccinated people by then. I think for now, nobody is suggesting that we are anywhere near the point where we can start taking off masks among people who we are not household contacts with. So keep using the masks.
Wow. Harriet asks, which vaccine is best for someone with diabetes?
They both seem equally effective, the ones that are out right now. There were diabetics in the study groups. There's no reason to think that diabetes itself would interfere with the vaccine effect. Diabetics, of course, are people who may have a variety of other conditions associated with diabetes. It's not clear that diabetes itself poses an added risk with coronaviruses, but people with diabetes of a certain age or with certain end organ problems from their diabetes may be at higher risk. So when either vaccine is available to you, I would go ahead and take it. Again, the only people, in my opinion, who should not be signing up to get the vaccine, or if they can, are people who have major allergic reactions to it in the past, to any vaccine. And that means you carry an EpiPen or you had to be hospitalized after a vaccine. Everybody else should be looking for a way to get this.
Rita, I love this question. Why did AIDS have a treatment but no vaccine, and COVID has no treatment but has a vaccine?
Yeah, good question. With AIDS, of course, it's been very disappointing that we have not developed a vaccine yet. much of the treatment of AIDS has hinged upon the blocking of its reverse transcriptase. AIDS, the HIV virus is a unique kind of virus in that it reverse transcribes its RNA into host DNA, and that gets into the chromosomal DNA of the person. This virus does not do that. So blocking that reverse transcriptase, which was an important step for HIV to gain access, that's been very effective. And the HIV drugs that do that or do similar things have gotten more and more effective, more and more user-friendly, et cetera. Now, why is there no vaccine? Probably for that same reason. HIV, when you get infected with it, causes no symptoms after the first few weeks. It causes no more symptoms for about 10 years. Why? It's because it's in this dormant place in your host DNA. Getting a vaccine to attack a virus that's in your cellular DNA is much more difficult than creating a vaccine that will block a virus like coronavirus from entering your cell. So again, we still hope that one day there may be an HIV vaccine, but I must say, I don't think we're any closer to it than we were 20 years ago.
Wow. Okay. Sandy asks, she wanted to know about with the problems that we have with the federal government distributing this and really focusing on this. The states obviously need help. Is there any idea what will happen once the new administration comes in? How President Biden can really push more, get more vaccinations out there, get more, medication?
Yeah, well, I think, we've heard from his call that all vaccine doses should be released and nothing should be held back for the second dose. That strategy has been challenged because we don't want anybody to not be able to get their second dose. So we have to look at how they can do that in terms of getting a lot of vaccine out. But I think no plan is going to be effective unless they come up with large-scale locations where the vaccine can be given. We have to vaccinate about 250 million people. And the strategy that New York State and some other states are now taking, opening up places like the Javits Center 24/7, Citi Field, et cetera, I think that's the strategy that's going to have to be implemented. Now, what the states need to do to get there, I think the Biden administration, maybe they need to look at a reward system for the states that are sort of behind on this and indicate that they would get federally supported vaccine distribution sites within their states if they would agree to enforcing universal mask wearing and getting a vaccine protocol up and running. I think there's not a state in the country that is not going to be in various states of panic about this. And hopefully the sort of troglodyte approach of we're not going to wear masks and we're not going to worry about any of this will become a thing of the past. But we're not there yet. And I think Biden has not released most of his plan. As we all know, he's appointed a committee to look at this. He's already been critical of the committee because he doesn't think they've come up with suggestions quickly enough. So while we're all looking at impeachment and the rest of the current issues, we have to keep close tabs on what's actually happening with this widespread vaccine rollout. If we ever want to get back to free travel in our country, we're going to have to be able to do this not just effectively in New York State. It's going to have to be effective all over the country. So we have to look at what's happening. We have to advocate where we can. And we have to keep in mind that we don't have a perfect approach yet.
Well, thank you so much, Dr. Masci. If anybody has one more question, I think we have time for one more. Just go into the Q&A and type it. But this has been so informative. I know so many people are, it's affected so many people and our loved ones. And it's nice to know that the vaccine is, you feel so positive that it's going to really help stop this pandemic.
Great, I'm happy to do it. And I'd be happy to come back and give updates on any of this. Are you able to distribute these slides to?
If you'd like, yes, absolutely. I think
Great.
we can
Okay.
send it out to our members and we'd be more than happy to do that. If you want to just email me that list that you had of the where to get the vaccine, who to call.
Yeah, that's on slide 49. So that's the next to last slide is where you can get information about it, who you should call, what websites, et cetera.
Yeah, there's one last question. Do you have source for COVID naysayers?
I'm not sure I know what you mean.
I don't quite understand that question, but
Well,
what do you mean, Justine, what do you mean by source? Please just type in something.
What I would say to naysayers is what I say every week on this radio show. If you want reliable information about this, just go to the World Health Organization or CDC websites. Forget Facebook and what other people are saying. Those are the websites that have reliable information. And you can believe them. I know the CDC struggled initially with getting their test rolled out, but they are very, very good. So naysayers, I would refer there. It's in English and Spanish and multiple other languages. But for people who are adamant about this, I think showing them numbers like I'm showing you, that there are 4,000 people being killed every day by this, may help. We have a variety of different projects where we're going to be reaching out to the local communities around Elmhurst to try to explain the value of the vaccine, address their concerns about it, their fears about it. We're all in the same boat on this one. Eliminating this from the Caucasian population is not going to be enough. We have to eliminate it from every major segment of our population. So again, speak to your friends. Let's keep an eye on this. And I can certainly keep you up to date on how we're doing with communicating this to minority communities. Before this call, I was on a call with the simulation centers in New York. This is a widespread network of centers at various hospitals that teach people how to simulate medical procedures and that sort of thing. And I think that that simulation strategy would be very helpful at trying to develop specific ways we can communicate to specific communities about this, what works, what doesn't, what gets the message across and what doesn't. But please allay any fears anybody in your immediate community or family may have about getting the vaccine. And keep in mind, if we don't reach at least 70 or 80%, it's all going to be for naught.
Well, thank you so much. Thank you for your generous time, because we know how busy you must be right now.
My pleasure.
All of this, we really appreciate it. So I just wanted to address the Reach Out America group for a moment. We're co-sponsoring a webinar tomorrow night. It's tomorrow night at 7:30. It's a community forum. It's the Great Neck Toxic Plume and whether water is safe to drink. Email reachoutamerica.li@gmail.com if you would like to get the link for tomorrow night. Next month, our meeting will be Spencer Sunshine. He blogs and follows extremist groups. He will give us a great insight and a backstage view of what happened on January 6th and possible future events to come. So please join us on February 10th. And if you've been enjoying our wonderful speakers and are not a member yet, we really urge you to please join. It's only $45 a year. We need your contributions to continue our great work and publicize these events. So please go on our website, reachout-america.com. Please don't forget the hyphen or you'll be donating to a different organization, and we really need the money here. So reachout-america.com and join us today, please. And thank you all for being here. Sorry for the technical difficulties. And again, Dr. Masci, we really appreciate all of your knowledge. Thank you so much and keep up the great work you're doing.
Thank you.